Hi. Peekaboo, it's Francis, and this is Immune Nursing. I definitely had fun putting this one together because I found all these stuffies of the immune system. So this one's going to be very cute. And as you can see, here is my antibody that has found his antigen. The antigen does not look very happy. This is going to be a quick one. So let's dive in. So normal immune responses, this is all oh my gosh, perimenopause brain. This is all review for you guys. And you can see that our immune response is going to help us with defense, homeostasis, and surveillance. And by the looks of that white blood cell, intimidation. That knife is not something most pathogens are going to want to mess with. So as you know, that's going on behind the scenes. We're not really thinking about it. We have all these different parts of our body that are surveilling and phagocytizing any kind of invaders or anything that's going to create a lack of balance in our body, lack of homeostasis, like in the lymph nodes, the tonsils. There's a lot of surprising different reservoirs here. And the one that isn't, of course, mentioned is that largest organ of the body, the skin. I mean, it does say skin-associated lymphoid disease, tissue, sorry, not disease, tissue. But, you know, it's the thing that's protecting us most of the time. It's when that first defense goes down that the second one has to come in. And we're going to talk more about, you know, first, second, and third. There's a really fun video here with the Amoeba sisters. I definitely recommend watching it, and it's great for kids too. Effects of aging on the immune system. The longer you live, the more likely things are going to go bad. Cells are not going to shut down when they're supposed to, and you're going to have a higher incidence of tumors. You are at a higher susceptibility to infection, which is why after a certain age, we really do encourage vaccines to at least give your body a fighting chance against a lot of these things that can take you out, especially the pneumonias. Pneumonias are very deadly for older folks and people with a weakened immune system. So we definitely want to keep our patients up to date on those vaccines. Thymic involution, that's another word for atrophy. So it just stops working, stops surveilling. And then, of course, a reduction in cell-mediated immunity. It's just not responding as quickly. And then those hypersensitivity reactions actually get dampened down as well, which for some people might be welcomed if they had to live with an autoimmune issue or anything that where they lived in kind of fear about how their body would respond to things. But overall, it's still not great. We still have to worry about getting sick more often. The spleen actually has a red pulp and a white pulp. And the red pulp is where it grabs all the damaged RBCs out of the blood and gets rid of them. The white pulp acts like a filter for the other bodies in there, like the macrophages, lymphocytes, etc. So it's always filtering the blood, which is why an injury here is so bad, because a lot of blood will go through the spleen. And if you remember from the earlier picture, it's kind of tucked behind the stomach and off to the side. We don't even really talk about it very much. But it's very important to getting our immune systems up and running and monitoring everything that's going on inside of the body so that it's managing all of that. Lymphocytes, aka granulocytes, removes dead cells, is a defense against infections and cancers. And today, we're going to be talking about all of these different things, but the one that we're going to talk about in HIV is the T helper cells or CD4 cells. So those will be the most important. And you can look at this little crew of lymphocytes that I found. I like that one guy's messenger bag. It looks really nice. And then I think that's a macrophage with the shower cap on. That's why it has a shower cap on. But these are really important. These are quite often lurking around in the nodes. They're monitoring what's coming in and out of lymph nodes to make sure that anything that can throw us out of homeostasis is dealt with properly. And then the CD8, the suppressor cells kind of down-regulate the immune responses to try and keep them in check. But as we all know, especially if you're learning about SLE or lupus, sometimes it doesn't work. So yes, this is a very important fighter in our arsenal. There's the macrophage again, about to take a shower. So macrophages are also agranulocytes, and they are also phagocytic. I had a hard time saying it. They go in and they get rid of the things that are there to try and hurt us. They deliver an antigen to a T cell and say, hey, go get this guy. And then the T cell will make antibodies and go find the antigen. Eosinophils are there for things like allergens and parasites, and they create inflammation to try to sequester and deal with the problem. As we all know, though, inflammation can kind of go out of control sometimes. We have to watch that. Neutrophils are an early fighter, as are mast cell and basophils, all both early fighters, so that they're sort of the first ones on the scene. And eosinophils, neutrophils, and mast cells, if you remember, are all granulocytes. So they also are phagocytic, and they engulf and then eat anything that they think is going to be problematic to our body. Yeah, and so we're going to talk about the hypersensitivity type 1 reactions, anaphylaxis. That's actually what the majority of this is going to be about today. So normal immune response, macrophages go and tell the T cells make antibodies, they go look for the antigens that they've been told are the bad guys, and then that's how we deal with this. So I have a picture of COVID-19 here, because this is one we've all dealt with within our lifetime. This is an FYI, primary and secondary immune responses. So you can see like what's going on over time, who's in charge, what's happening. And then you might also recognize IgM, IgG. These are things that maybe if your immune response isn't working or it's working too much, we may get infusions of some of these to try and correct the way that our body is responding. So those are really important to know about. All right, so this is a video, 5-minute video about hypersensitivities to watch prior to moving on. There is a mnemonic, the acid mnemonic. Type 1 is going to be the anaphylactic reactions, which we're going to focus on today. Type 2, the cytotoxic reaction. Type 3, immune complex mediated reactions. Type 4, delayed reactions. And there's actually a 5th one, which is associated with Graves' disease, because I know somebody out there in the class was very interested in that one. So take your time to watch this. Going back and talking about it, we're going to get more in depth about anaphylaxis, but just so you know, type 2 or cytotoxic reactions are things like the Rh factors that we have as the baby carriers, the fetus carriers, the life givers, the ladies, talking about y'all. We're always looking to make sure we have compatibility with the things that are growing inside of us, unfortunately. And so the Rh factor is one of those cytotoxic reactions. Also, myasthenia gravis is also a cytotoxic reaction. Third type, the immune complex mediated, that's like SLE or lupus. The 4th one, delayed reactions, that things like poison ivy. And then there's a new one now, which I don't know if you've heard about, but there's a tick bite that creates this delayed reaction where later you get this terrible allergy to beef. And somebody, I think, just died in November of 2025 after ingesting beef and having had a tick bite a few weeks before. So that's that delayed reaction. It's real. I think it's mostly on the East Coast right now, just like a lot of Lyme diseases, but still something to think about. So let's talk about type 1 or anaphylaxis. Here's my cute little mast cell filled with his histamines. That is killing people, 1,500 deaths annually. And it does sound like it's getting a little better, at least in terms of some of the allergens like peanuts, etc. We're not having as much problem with peanuts, but we've also taken them out of the schools. They're not on planes anymore. And that, I believe, had something to do with children who had some of these allergens come through their skin, from the air before having had it come through their GI tract. And it seemed to be causing these hypersensitivities if it was skin before GI. If you could somehow maneuver GI before skin, then you might have had a better chance, but then you could also introduce in very, very small amounts some of these allergens to people that have these hypersensitivities to try and dampen down their immune responses. So we are working on this because we know how deadly some of these responses are. So the list of allergens are food, insect bites, stings, and injections. You can have inhaled allergens, and then, of course, environmental sources. Shellfish, as we all know, is the thing that we're worried about as an allergy if we're going to be giving someone contrast for imaging, like a CT. Shellfish, iodine, those types of allergens are things that we have to let people know about if they're going to get imaging done. There are medications that are causing hypersensitivities as well. And then the other big thing, the purple gloves that we're using in the hospitals now, they used to be latex gloves, but we did find that that was more problematic to a larger population. So they changed it over to this polyurethane or something. I forget what they are. And then there's a weird connection between a latex allergy and a avocado allergy, and sometimes mangoes too. So that's why I have my cute little avocado there, because he could kill you. All right, so moving on. Physiological responses. We're going to go through each one of these, and I want you guys, this is a slow number 15. That's what this whole section is slow 15. We're going to talk about whether or not it is a localized reaction or a systemic reaction, because that helps you understand more how to battle it. So the first one right off the bat is a localized redness and swelling. It tells you it's local. So you can put an L right there on localized redness and swelling. Flushed skin and ears, also local, but angioedema, so that's the swelling of the vessels, that's systemic. That's everywhere in the body. And it may start in one spot, but it will spread. So you want to make sure you write down S for systemic for angioedema. Urticaria actually technically is local. If it does spread, you'll know it has become systemic. Rhinorrhea, also local. Watery nose, watery, itchy eyes, local. Nausea, vomiting, pain, diarrhea, and cramping, actually local. Because most likely you ingested something, and so it's locally trying to manage the hypersensitivity. Bronchospasm and wheeze, systemic. Cough, local. Because if you think about it, your cough is trying to eject something. But a bronchospasm and the inflammation that can cause wheezing, or the bronchoconstriction that causes wheezing, actually are systemic because it's coming from other sources. But cough is local. Hypotension, syncope, and tachycardia, all systemic, because it's like a late response where your capillaries start to dilate, and so you get hypotensive because you're not able to maintain the blood pressures, and that also causes your capillaries to become really leaky out in the periphery, which can cause syncope on top of the low pressures. You can pass out, and then your heart's trying to catch up by pumping harder and harder and harder. So that's where you get your tachycardia. So just another way of figuring out where exactly all these different issues are going to reside, what to look for with your patients. That soon as you start seeing anything in the eyes, my tongue feels itchy, you're on it. You cannot ignore stuff like that. You have to stay with your patient is really the main issue, because you don't know where this is going. Have them drink some water, make sure they can still swallow, that their throat is not closing up. You want to be with them, and then you're just calling everybody in as soon as you can if you're worried that this is potentially an anaphylactic reaction to something. All right, this whole slide you definitely need to know, okay? Know this slide. All right, so epinephrine is your first line of defense against an anaphylactic reaction. And surprisingly, it's IM. That's what the book says. And if you're not responding to IM injection, then you'll try IV, because maybe if you look at the bottom of the page, maybe your patient could be on beta blockers, which could be dampening down their response to the medication. They're clearly having a reaction, and the epinephrine is supposed to tackle that, but sometimes beta blockers will block that. And what do you do if someone has a beta blocker reaction or too much beta blockers? You give them, what is it? Glucagon, oddly enough. So IM sub-Q is fine also because your body can process it at the sub-Q level. But usually IM is first, IV if that's not working, sub-Q if that's not working. Just trying some different things. And in the hospital, you'll be able to get auto injectors. If you know of anyone or are ever talking to anyone or you yourself have ever had anaphylaxis or the potential for it, you always want to carry 2 auto injectors, okay? 2 auto injectors for epinephrine because you might need it back to back, and you got to have something with you while you're waiting for the ambulance to come and get you and keep an eye on you. So just keep an eye out for that bronchodilation. That medication is very slow acting. And again, tachycardia. Your heart's going to start trying to correct what's going on. And by pumping blood faster, it can do that. So second line is usually the antihistamines or the H1s. Remember, H is histamine receptors. So we have histamine receptors. And we also can use H2 receptors. And you guys remember what that one is? We learned that from our GI, famotidine or Pepsid. A lot of times if you're having a systemic response and you're at home and it's not here necessarily, taking your Benadryl with Pepsid can help increase because you're hitting your H1s and your H2s at the same time. And that's very helpful to get your body to quiet down an immune response. And they'll tell you that in nurse advice, or they'll tell you get to the hospital right away. So let's talk about Benadryl. PO is never first line because you're swallowing it. Then you got to wait. Your stomach has to churn. It has to break it down. Then it's going to pass through your liver. Then maybe you'll get enough of a blood load that you can actually start managing some of the reaction. But it's going to take 20, 30 minutes minimum to get going. So if you're ever worried, bring something that's sublingual that can go under the tongue. And so you probably want to have in any kind of first aid kit a sublingual Benadryl and a PO Benadryl. Both of those are fine. You might even be able to do like a topical Benadryl, but that's going to be second line if epinephrine is not working. And we're really talking about with anaphylaxis. Corticosteroids are also very helpful as a second line, to quiet down and take away some of the inflammation. We talked about H2 blockers or famotidine, and then also things like Singular, which is the leukotriene antagonist. Our receptor blocker, that Singular can be really helpful. So looking at Benadryl, we know there's a lot of side effects to Benadryl. It's very sedating. For some people, it makes them really hungry. You get a really dry mouth. It kind of just dries everything up. And that might not be a bad thing. You might need that. But taking them over and over and over is not really great. So you'd probably want to switch to maybe what we call a second generation, like the Claritins, Allegras, Zyrtec. Those are the second generations, whereas Benadryls or diphenhydramine is the first generation. So they got better and they got longer lasting with less side effects. So this isn't a good one for every other kinds of reactions initially. And then you might want to transfer over to a second gen to maintain your fight against your reaction. But for anaphylaxis specifically, we're always talking epinephrine. Okay, let's move on. Further treatment, you're definitely going to probably want to have your patient on oxygen while you're monitoring them just to make sure things are getting oxygenated. You don't want them going into any kind of fermentation, lactic acid buildup, none of that. Vasopressors, because you're going to want to correct all that vasodilation, and then IV fluids to help maintain your blood pressures once you are correcting the vasodilation. And again, we talked about corticosteroids as a second line. It can help prevent further anaphylaxis, but it's not for use for years. It's just for, right now while we're figuring out what happened and how to help our patient go home and feel confident going home. Laying flat will also help keep the blood at the brain, and elevating legs can also help keep blood going to the brain. And as the nurse, you're going to have to make sure that you're teaching your patients about what to look for, signs and symptoms. Show them on their phone what to look at, a picture of what it is, when to call, making sure that you're telling them about having at least 2 epinephrine injection syringes so that they can call 911 and then keep an eye on whether or not the epinephrine is working or not, and then shooting themselves a second time if necessary. I actually just have a friend who, over the summer, I think it was right before 4th of July, she's a firefighter, and luckily she's a little bit of a klepto in that there are these epinephrine pens that they're going to throw out at the firehouse because they were out of date. And so she grabbed some because she lives up in the mountains and she's pretty far away from everyone. So she said, well, I'll just keep them at my house just in case. And she went away for a couple of weeks. And when she came back, I think spiders had taken over her bed in her bedroom. And she said she got bit multiple times on the neck and realized that her throat was starting to close up. So luckily she had those outdated epinephrine pens, shot herself, and it's started to help, and then it came back. And so she had to use a second one to maintain it. So that's what I mean by IM. Like, you're always giving it to yourself IM. It might end up being sub-Q for some people, but you're attempting IM with the depth of the needle. And luckily she was able to quiet it down. I told her about the H1H2s, how to manage it. She tried calling nurse advice, and because it was almost 4th of July, nobody answered the phone. So you really want to make sure that you're guiding these patients to let them know what they need to do. If they have any inkling that anaphylaxis could be part of their reaction to the world, if they've had times where their lips have swelled up from a mango or something like that, you're going to talk to them about what anaphylaxis is, because even though it might not happen, it could happen. Having oral Benadryls, again, remind them to have both sublingual and PO so that they're covering all their bases for that second line. A medical alert bracelet will be really helpful because if someone finds them down because they're not breathing, at least they can figure out that there is something going on here, and a medical bracelet will alert the providers as to what's going on. And then, of course, referring to an allergist to deal with how their body is responding to the environment. Okay, I hope you guys had fun with this one. Hope none of you guys have this, but, it's around us. So just be prepared. Thanks, guys.